to the show. This is the Mr. Shock show. We're going to teach you how to do the MRA coding in your office. So what she's going to talk today is how to bring that knowledge and culture to your office. And we want to help. We want to thank Daryl who arranged this program. And like last time, it went through without any hitch. So Kerry, take over. No, before we go there, I want you to tell me all these things you have, CPC, CDC, all that thing. Tell the audience what they mean.
Okay, well, first of all, I have been doing this for chart reviews for about 27 years. I currently am a certified professional coder. I am certified in risk adjustment coding. I am certified for medical auditing of records, and I'm a certified documentation expert. Soon to be a certified instructor. Hopefully, fingers crossed. But I have been doing this for about 27 years, and I've seen quite a few records. So hopefully, I'll be able to teach everybody a little bit something today. You'll walk away with something that maybe you didn't know prior to this. That is my goal.
So Kerry, go ahead, and all these questions, please send the question to the chat, and we will answer them. Kerry, leave enough time to answer those questions. So Kerry,
yeah, this will be a little bit briefer than last time. So tonight is part 2 of the 3-part series. We're going to talk a little bit about some of the new patient protocols that we use here in Florida that we find very, very useful. And then we're going to narrow down some of the diabetic protocols. We're going to talk about some of the diabetic complications and how to code them. Then we're going to get into a little bit of the importance of a chart review. We're going to review some results of some random chart reviews that I did from one of the offices out in Georgia. And then briefly, we're just going to wrap it up with some best documentation practices, what should be in your assessment and plan, and your encounter submissions. Let's see. Okay. So here in Florida, we kind of use a protocol for our new patients, all our new members. We have a bucket list or a laundry list that we ask all of our providers. You should, for new patients, order a lower extremity ultrasound, and that's where we would find any atherosclerosis of the lower extremities. And let me just say, any amount of plaque found on that ultrasound, is eligible to be coded. We also ask that they do either a chest x-ray or an abdominal ultrasound, and you can see the diagnosis that we typically find from those x-ray or ultrasound. Also, we ask our providers for order a spirometry or PFTs, especially for patients that are smokers, secondhand smoke exposure, or ex-smokers. We always ask that the providers order at least a baseline, and we're looking for any form of obstruction. We have a list of labs that we order. We always order the A1C, the CPM, CBC, and a TSH. From there, we can get quite a few diagnoses, as you saw on the list. But what we do now for the diabetes, we also have, excuse me? Okay, I'm sorry. I thought I heard somebody. For your diabetic patients, we have a secondary panel of protocols. So the labs that we order on our diabetic patients, we order microalbumins. They should be done yearly. Your CMPs, your A1Cs, and your lipid panels should be done every 6 months. We also encourage the providers that the diabetic patients should have an eye exam. They should have a baseline, the arterial or abdominal ultrasound and a chest x-ray, and they should, if applicable, should have a baseline nerve conduction study.
So Kerry, let me tell you, I want to represent the physician from Georgia. Okay. And you can teach me. So physician in Georgia would like to know, before they order something, they got to know why they're ordering it, and they need to have enough evidence to do nerve conduction study, as a baseline, we usually will not order it unless patient complain they have symptoms or we have evidence, clinical evidence of neuropathy.
Exactly. And we order it as a baseline, if applicable, based on if there was clinical indications, order it. We wouldn't just necessarily order the nerve conductions, but if you have a patient and during one of your visits, you know, it presents that there's numbness and tingling, and there's an indication that there may be some form of neuropathy, you know, the neuropathy itself can either be diagnosed by clinical exam or it's supported by a nerve conduction study. But if there's that underlying presentation of numbness, tingling, burning, loss of sensation, you know, we would then, more times than not, the physician would order a nerve conduction study.
So what you're saying to us that in order to properly code and do MRA in diabetic patient, we need to have these data. If patient have symptoms, so we need to look for the symptoms like claudication or numbness in the leg, so we can get the test done and accurately code the patient, right?
Correct. Correct.
So Carrie, I have a question. Carrie,
Sure.
This is Dawn. Can you hear me?
Yes.
So what about if another physician has done any of these tests or some of these tests and you can't get the results for the documentation? How do you handle that?
Well, you would hope that the other provider that has done those tests, that there's a you know, professional relationship. Typically, you know, our providers will send a medical request, you know, for records.
But can you document that in the chart, or do you actually need the results in the chart?
You could document it, that it was being done, that it was done, and who did it and the date of the test, but it is ideal to have it in the chart.
Got you.
Because without it in the chart, there, you know, you're going to look for some clinical findings. Because remember, every progress note, every note is a standalone record. So if you don't have reference to that diagnostic test that truly supports it, then you need to have reference to the clinical exam that initially diagnosed it. So the best evidence is the study, but if not, what you want to do is reference back to the initial clinical exam that diagnosed the neuropathy. So
Kerry, one time you diagnosed that last in 2019, and you have done this test, and this diagnosis has been done. So those things are not going to change. So in 2020, do you want to do again, or you just take the data from 2019?
No, what I tell the physicians is, for example, if you diagnose it, say January of 2019 by clinical exam, what I would put every time I assessed it, you know, positive clinical findings, January 2019, currently stable, continue gabapentin. You know, it's as simple as that. So some of those things, like we talked about last time, could be hard-coded in your problem lists. You know, the initial onset of the positive exam could be hard-coded into your problem list, so that always populates every time you use the condition. And a lot of your providers, I think, have ECW, which is very easy to hard code that information. So some of the things that we get from these labs and different studies, obviously from your CMP, you know, and your microalbumin is where you're going to find your chronic kidney disease. So here we'll give you the parameters for nephropathy. You're looking for, you know, a positive microalbumin or the urine protein 1+ or higher. For your CKDs, for stage 1 and 2, you need a positive microalbumin and a GFR above 60. So you'll need one of each of those for stage 1 and 2. Once you get to stage 3, your only qualifier is the GFR score. And based on the score is the appropriate stage, 3, 4, or 5. And then, of course, stage 6 is on dialysis. And don't forget to use the code for dialysis status. Your eye exams, most diabetics, as far as HEDIS, have to have that eye exam if they're positive retinopathy every year or a screening every 2 years. And it's those exams that would actually bring to the surface any type of retinopathy, whether it's background retinopathy, proliferative retinopathy, diabetic cataract. The one thing that a lot of providers don't realize, for your patients, for your diabetic patients that have macular edema, even once it's resolved following the treatment, it still codes to an MRA code. And a lot of providers don't realize that. So any of your patients that have that acute macular edema, they've been treated, it's resolved, you actually still can code for it and get a score. Your neurological complications is your neuropathy.
Kerry, let me bring you back to eye exam. Eye exam is the most difficult portion of general medicine here in Georgia. So, for example, a patient go to eye doctor.
Mm-hmm.
You know, we have to push the patient to the eye doctor. Now they should code, and that should go to the Medicare. Or do they need to have the documentation to our office and we recode that?
So that's a very good question. Typically, the ophthalmologist would obviously, once it's diagnosed, they would submit it. What I tell providers is that while the specialist may submit it, if that patient doesn't go back in a timely manner and you don't have it in your records and you don't routinely document it, you run the risk of losing the score the next reporting period. So I always tell my providers that even though you know that they've gone to the eye doctor, they've been diagnosed with retinopathy, he submitted it, so you're getting the score, which is fine. But if that patient doesn't go back for 15 months because she's late with her next year's eye exam, you've actually lost that score for a reporting period because you, as the primary care, are not submitting it. So I always tell my primary carers, as the gatekeeper and the manager of this patient's health care, you should be documenting all the conditions and not relying on the specialist to do it, because they don't do it consistently and your score will fluctuate. So I would suggest that you always go after these reports and you routinely document the status of the condition as the primary care.
But Carrie, I have a question. Since we are not coding for, or we are not treating it, how can we bill for it?
So you simply you would put it in your assessment, and then you would just simply say, for example, background retinopathy, currently under the care of ophthalmologist. I mean, you don't have to be treating the condition to document it. Your responsibility is to document any condition that you are monitoring, evaluating, assessing, or treating. So if you're just monitoring the retinopathy and that the patient is going to the eye doctor and you've got the report on file, that's simply all you have to document. That you're in the condition, you know, you're monitoring and managing it, and it's currently being treated by the ophthalmologist.
Hi, Carrie.
I'm sorry,
Don't go to sleep.
I couldn't hear you.
I'm going to ask the question here, Rich, from the Dr. Prani. And
I have to.
Can we order abdominal ultrasound or arterial Doppler with the diagnosis of diabetes? Will it cover? The second question, can we report MRA even if the specialist already documented in that year? So these two questions. Question is, I think the second question was already answered by you. What she's saying is the specialist already coded. Do we need to code again? And the second question, can diabetes cover abdominal ultrasound and PBD, arterial Doppler sound of the leg?
That one I would have to look up and give you an answer. Coming from an MSO and a risk environment, we don't have to establish medical necessity. So I'd have to see if the diabetes code alone would do it. There are screening codes, you know, that would allow you to do these as a baseline. And let me do a little research and I'll provide them for you. But again, you know, as far as the specialist, it's fine if the specialist is documenting them, but do not rely on the specialist to continually document them in a timely manner, because you're going to find that there are more chances that you're going to lose that score because the specialists aren't coding them consistently. They're selecting the wrong codes, which, you know, a code off by a digit could mean a score versus no score.
So Dr. Seni answered the questions. The first question of Dr. Parani is, say the PAD evaluation with ABI in diabetes is covered.
Yeah.
So if you have diabetes, you have PAD, you do ABI, that diagnosis and that CPT code is covered with diagnosis of diabetes.
Yeah, I do believe diabetes covers them all, but I would look on my sheet and get back to you before I confirm that in a public forum. 99%.
I have one question for Carrie.
Sure.
So let us say we are doing the, you know, the coding, and the ICD code, the only you can put is 4. In, let us say in eClinic EMR. So how you are, let us say you have 10 different code, how you are going to do that?
So you should
how Medicare will know?
But you should be 837 compliant, be able to submit 12 diagnosis codes.
Who is that? I'm sorry.
I mean, CMS, it's been a requirement for several years now that you have to have, your systems have to have the capability to submit at least 12 diagnosis codes per encounter.
Okay. Anybody has eClinic that can tell me if that is the situation that 12 diagnoses can be entered?
Harry, this is Dr. Saini from New Jersey. No, we are allowed not more than 4 diagnoses.
4, yeah, that's what I'm asking.
So David, can you chip in and tell us what we should be doing or what your experience is?
Yes, there's a setting in eClinicalWorks that limits the amount of diagnoses per line. And then you got to make sure that's unchecked. And then if you're in the ACO, just call your consultant and we'll show you how to submit 12 in eClinicalWorks. But you can do 12. You just got to make sure the setting's not there and you got to attach it to the appropriate lines.
Consultant means the ACO consultant, or you're talking about eClinic consultant?
ACO consultant.
Okay. Thank you.
Okay, so getting back to these are, you know, some of the diabetic retinopathy conditions that exist out there, the most popular. Really just want to bring to light the macular edema. Even though it's resolved, it's still reportable. Your basic neurologic, your neuropathies, again, it can be diagnosed simply by clinical exams. You know, your monofilament tests, your tingling, burning, numbness, loss of sensation, you know, all of those positive findings is enough support for neuropathy. What I tell all my doctors is, you know, when you're examining the feet, you know, I mean, you should be at least once a year taking those patients' socks and shoes off, looking for any amputations, anything like that, because, you know, amputations also are a separate score. And then, of course, you could, oops, sorry, let me go back. How do I go back? Oh, sorry. The nerve conduction studies. If you have one, if a specialist has one, if it's obtainable, that's your best source of documentation, but clinical findings are absolutely fine. You just have to know that you need to document the actual onset of the positive exam. PVD, the same thing, certainly can be diagnosed by a clinical exam. Again, document the positive findings when it was originally diagnosed. And then, of course, the other form of support would be your arterial ultrasound and your ABIs. Again, when you're examining the feet, you know, there's also, don't forget about amputations. That will get you the second score. Diabetes with other complications. Do not forget your diabetic ulcers of the foot and skin. And they clearly are done by clinical exam. The main thing is to make sure you document the site, the stage, and the size of the wound. Some other complications that we see out there is the diabetes with periodontal disease, hypoglycemia, hyperglycemia, and then, of course, the dreaded diabetes with other specified complications. And typically we use that when the patient has ED or some type of cholesterol issues. However, when the description says other specified, you have to document the relationship between
So
the
Carrie, let me talk to you about a little bit about this is
Mhm.
awesome presentation of diabetic coding. So I saw a patient today, well dressed and nice boots, and basically didn't tell me anything about the diabetic ulcer. So I just started asking question. Do you have a diabetic, any complication or diabetic ulcer? Then he
Mhm.
said, yes, I have big toe. That ulcer been there for about a year. I'm helping her. So the question, main thing is we need to get in habit of asking all these questions to a
Yeah.
diabetic, whether diabetic
Correct.
looks healthy or unhealthy. Is that right, Carrie?
Yeah, absolutely, absolutely, and especially with your diabetic patients, you always want to periodically ask those questions every time they come in. You want them to take those socks and shoes off. You really need to physically look at the extremities, because what they don't perceive as an ulcer or an issue, they're not physicians. You, as the physician, really need to examine those extremities to look for skin complications. Because a lot of times they're out there and you just don't realize it until they become so bad. But definitely have them take their socks and shoes off.
So
So,
I want to introduce David Klanavis. He said, okay to add ICD-10 from specialist progress note in your assessment. Just please put in your plan managed by specialists. And ICD-10 must be billed to code towards MRA. That's a very important point. We didn't know about that. And thank you, David. So what David's saying and Kerry's saying is, if a specialist note is in your chart, based on that specialist note, you can add that in your MRA and just a plan that's being followed by specialists. That what you're saying, that as a primary care physician, you are observing the complication under specialists, and then you can
yes.
code that and properly code that to appropriately reflect the MRA. Is that right, Carrie?
Yes, correct. In your assessment, you would just reference, for example, patients being followed by ophthalmologist, currently stable. C report, you can, C report dated August 31st, 2020, currently under care. Any reference to that report that you have in the chart, because again, you only need the criteria that you need to meet to support these conditions is you would need to be monitoring or managing that condition. And by monitoring or managing, it means you have oversight that the patient is being treated with a specialist. You need to be evaluating the condition, assessing it, or personally treating it. And as long as you document and meet one of those criterias, then that you are absolutely within your rights to document and code those conditions. You just
Carrie,
have
I'm
to
typing as your assistant. So as you're saying these nuggets, I'm just typing them in the chat.
Okay. So now let's get into the actual reason or the benefit to do chart reviews and go through these charts and go through all the documents that are in there. The main purposes of doing the chart reviews is to obviously track the conditions that the providers are documenting, identify if the provider's code selections are incorrect. It also reveals coding conflicts. If the providers are coding, for example, with a complication and without a complication, it identifies conditions that are not fully supported within the documentation. So there's an education opportunity back to the physicians. And it also reveals conditions that are inaccurately coded that should not be coded, such as cancers that have been resolved. And then, of course, the additional conditions identified by coders that have not been documented at all. So those are the things that, you know, when you go through and you do these chart reviews, these are the benefits and the things that you want to track. So having said that, I had an opportunity to go through one of the physicians, just a couple of charts. So I just wanted to show you that based on a chart review, you can see that this is patient name, this is case 1. Currently, the provider was documenting morbid obesity, which is an HCC of 22. The BMI certainly qualified. Okay, that HCC landed him a score of 0.25. That was the only condition that that provider had been documenting. However, once I went through the chart, I found that there was major depression. There was a PHQ-9 on 6/22 of 20 that the score came up severe depression, chronic obstructive asthma. There was a PFT on file back in 2/23 of 2018 that indicated moderate obstruction. There was sick sinus syndrome that I found on previous medical records. Sedative dependence, again on previous medical records, and I provided them the page that they could review that. This patient had also been diagnosed with bipolar. They've been diagnosed with chronic diastolic CHF, and the patient records again, Dr. Thomas Martin on 2017. And then of course the morbid obesity, which the provider had been documenting and is valid. So again, remember the doctor, based on his current documentation, that patient's MRA score is 0.25. If you factor in everything that was discovered during the chart review, that patient's actual MRA score is a 1.822. So right there, there is a score of 1.572 that was left on the table, unaccounted for. So these are kind of the things that you find when you go through the chart reviews.
So when you
Okay,
have
let
a
me ask you
score
this
is high,
So this,
when you
I
have-
see this patient 4 times a day, so 4 times or 6 times a year.
Mhm.
Patient came quickly, and my nurse said morbid obesity, and went away. The next note was a little bit more detail, had 2 or 3 of these. The next note had 2 or 3 more, and the next note has a little bit more. So the cumulative diagnosis may have included all of those. Will that satisfy the way we should be coding, or all these codes should be on one single billing system?
No, they do not all have to be documented on one visit. Each condition must be documented. Well, the CMS requirement is each condition must be documented once per year. Okay, so you could on one visit maybe assess the major depression, the chronic obstructive asthma. On another visit, you may have addressed the sick sinus syndrome. As long as you get all of these within the year, you're good. Now, we talked about in 2 weeks ago that we tell our providers that we follow the 6-month rule. Because if you're doing it once a year, there's an opportunity there that if too much time goes by, you lose the score. So because of the way that the CMS has their reporting periods and their reconciliation periods, we encourage the providers to document all these conditions twice a year. But again, it doesn't all have to be in one visit, but the ideal opportunity to do it is at their annual wellness. When you're going through their health and you're going through all their conditions.
So Kerry,
That's-
can you put the
that's the-
money part? 0.25 means how much? 1.572 is how much?
I can't equate it to you in dollars because, this is just a raw MRA score for the conditions, and everybody, we all understand that there's a lot of other factors and things that go into the formula for a true MRA score, the patient's age demographics. There's then additional scores for a combination of coexisting conditions. There's additional scores once you have a patient that has 4 or more MRA scores. So it's very difficult to equate this base score to a dollar sign. But it's significant. I mean, you're talking about 1.6. That's a huge amount of money.
So what the payment is based on the score?
Well, the payment is partially based. The member score is partially based on the score from the MRA conditions. Then there's added score values for the patient's age and sex demographics. There's also scores for once the patient has 4 or more chronic conditions, there's additional scoring that's added in. So this is not the patient's total score, but this is the score that represents their health conditions.
No, my question was like, so let us say for 213 office visit, you get $50. I'm just throwing you a number for 213. And then, so if you have a better score, you get more?
Not if you're getting paid fee for service. You're going to get paid the allowable for the level of the office visit that you code.
So what difference it makes if you have a score is 1.25 or 0.25 or 1.82?
Well, that ties into your risk contract.
So David, can you take that? Just explain that a little bit more.
Sure. So,
How it is important that
if you have a Medicare Advantage contract, like what Carrie works on, if the doctor doubles their MRA score, they can earn maybe 75% more in a year on the visits they provide. Carrie, do you agree with that? Am I close?
Yeah, you are very close. So in my world, the providers get a monthly capitation. In your world, you do get paid fee for service, but then the risk score comes on the back end.
Right. So if you have a Medicare Advantage contract like the one Carrie works on, it's directly related. There aren't many of those contracts, but in the ACO world, you can benefit your payment, but not as much. So if you double your score, your payment might go up like 5 or 10%, because the ACO caps how much you can increase your MRA score, and they cap how much you can increase your benchmark. But it's still helpful. I mean, if you're learning these codes for other contracts and it doesn't take you much time to add 2 or 3 codes to the chart, or even 1 extra code to the chart, every little bit helps.
So David, I have a question.
Can I add one more thing? I think how the Medicare define that you are high quality and low cost physician. It depends upon the MRA and how much money being spent. If you say spend the same money, but the MRA is different in 2 patients, in which category? Just David, go and explain that. So why it is so important, even for in the fee for service basis.
So on various reports from Medicare that are part of public record, like the QRUR, Medicare looks at your cost per patient and they look at your risk score per patient. And they factor in if your patients are sicker based on the ICD-10s you bill. And it's possible that you can be higher cost, but because you're billing more ICD-10, Medicare will still say that you're high quality. There's a lot of benefits to accurately coding the ICD-10. You know, maybe you order a lot of home health, and if you don't code adequate ICD-10, Medicare is going to believe that you're overutilizing, and they might send you a letter. But if you're coding ICD-10 and it shows that your patients are twice as sick as your peers, maybe they don't write you that letter. As Dr. Agrawal says, it improves your quality scores potentially because it says your patients are sicker, and maybe it justifies the costs. And then finally, it can help your ACO payment by like up to 10%. The only gotcha is the codes that you bill now will increase your payment next year.
So, David, can I ask you a question?
Yes, ma'am.
Okay, so I've heard all of that, and forgive me because I do come from the MSO side, but that benchmark of a maximum 3%, is that a correct, fair assessment of how much you can increase?
Yes, ma'am.
Okay, so but that is across the board. That's not at a patient level, correct?
Yes, ma'am.
Okay, so the reason why you want to maximize and document all of these conditions is because you also need to account for those patients that miss appointments, you can never get into the office, that they're just out there wandering around, you know, that you're not able to submit their MRA scores, you know, the excess above and beyond that you're submitting for your other patients is going to level that out.
Absolutely. Carrie, when you work with an office, what percentage do you increase the MRA score sometimes?
It's, you know, on an individual level, it's difficult. It's average of maybe anywhere from a 0.75 on up on an individual patient level. But throughout the years, it typically goes, you know, we've gone from say like a 0.9, and within like 2 years, they're at a 0.5, 0.6, 0.7 across their board. So, you know, we strive to get as much in because in the practice, the offices, it's typical for 15% of the membership to go undocumented in a given year. So you need to make sure that you are robustly submitting for that 85% that you have the opportunity to make up for the 15 that you never see.
Right. And then, so the ACO's approach is let's take all the great things we learned from Carrie, but we don't have to do it as well as she does. I mean, that's at least a 50% increase. So if you're able to do some of this and your increase is 10%, for example, you know, considering that some patients will go down, you know, some doctors will go down, you know, 10% is a good number. And then that way your ACO can get like another $2 or $3 million a year, and then you would get that percentage. But there's a big difference between what Carrie does and then the maximum what you can do in the ACO.
Correct.
So it looks like there is still really advanced confusion between fee-for-service physician versus risk-taking physician. And I think during this seminar, we will keep talking about that and try to clear that view that even if you are fee-for-service physician, time has come to change your practice in your office because people watching you, whether you are high-cost or low-cost physician. So proper coding is really vital to able to show that your patient is sick, and that's why the cost of the caring of that patient is higher.
And let me also just say, it is the responsibility of the physicians to accurately portray the member's health status by virtue of diagnosed coding. You know, we talk a lot about MRAs and scores, but, you know, I mean, these are conditions that your patient has, and you as the physician are, you know, in a sense obligated to report that data to, you know, the government. Not all at once. It could be on various different notes, but, you know, you want to make sure that you are submitting an overall accurate health assessment of your patient.
So Carrie and David, I would like to take this moment to introduce our guest here, Dr. Mehul Patel. Dr. Patel, can you hear me?
Yeah, let me unmute myself. Yes.
Very good.
Yes, Dr. Agrawal.
Let me tell you a little bit story about this. So in last 5 years of ACO, we have saved money 3 years, and we distributed money. This will be, again, we distribute money for 2019. So we have established ourselves as a doctors ACO group. It's a high quality, low cost physicians. So that, we are, you know, obviously, you know, people looking at us. So Dr. Patel, Mehul Patel is from Tampa. He has experience in using this group of physicians who are high quality and low cost physicians. So Dr. Patel, can you tell us what's the advantage of this? What can happen so the fee for service physician can hear what good thing can happen to us?
Wow. I mean, definitely I'll try. It's really a pretty wide gamut to, you know, to try to cover, but I'm very impressed with the group and the conversation, the discussion that went on. This is amazing. So hats off to you all. Obviously, as David and I'm sorry, Carrie, right?
Yes.
Yeah. As they have alluded, that essentially a lot of these have direct financial impact on providers, primary care providers who are under risk contracts with Medicare Advantage. ACOs are getting under the risk contracts also, and from what my understanding is that doctors ACO might be under some sort of risk gain sharing for the coming year. I do agree with David, as he alluded, that the benchmark is tied down. Benchmark does not go up prorated to the MRA scores in ACO world as a rule of thumb compared to Medicare Advantage, because it has other scaling factors. It is blended with regional and national benchmarks. So overall, but it can go down if the MRA score drops. So that is apart from the dollars and cents that he rightfully put out, what it amounts to based on the total premium. Obviously, reducing or losing MRA score actually is definitely detrimental. And as both of them have alluded, a lot of times you don't capture all and report all. So you have to do the best to portray the condition as is for every patient that you see, and at least retain the MRA and or increase it slightly. On the separate note, I think this group is practically ready for a Medicare Advantage contract, and definitely I'm more than happy to have a conversation with all or whosoever might be interested for the group to participate in Medicare Advantage with risk sharing eventually, because I do feel the level of engagement and awareness and the proof is in the pudding that already 3 out of 6 performance years there has been share of savings. The other 3 it did not for various reasons. I'll pause with one thing. Undercoding is as much as a lack of standard of quality of care as overcoding, and that might answer the question from one of the doctors who rightfully said, my 99213 is going to pay me $50 no matter what. But technically, Medicare actually does not want us to undercode either, as much as they would not want us to overcode. So I'm more than happy to answer specific questions, Dr. Agrawal. This is a fantastic group, great conversation. I'm very excited to see if we all can have a some sort of collaboration and grounds to work together.
That's good. Thank you, Dr. Patel. Appreciate it. And I think, David, why don't you just add this to everybody to hear this, what MRA can do to ACO with 150 patients and 3% increase in MRA.
Yes, sir, absolutely. So, 3% on an ACO is a lot of money. That would result in a payment of $3 million. And then just to be conservative, after expenses and, just to, some positions higher, some positions lower, doing MRA based on what we learned on this call can be $10,000 per PCP.
That's eye opener. Most physician, fee-for-service physician, they don't know what happens in Florida. We need to just learn from them. So go ahead, Kerry. We just did just like intermission. Go on. And
It's just I just go through. Same thing. I have some more charts where you can clearly see what was being submitted here. Was a 1.323. After the chart review, this actual score should be a 2.63, a difference of 1.307. So it is eye-opening as you start to go through these charts and truly identify what is in those specialist notes, what are in some of those lab results, because there are a lot of scoreable conditions that need to be documented. And again, it is the patient's health status. You have an obligation to report it as such. Again, this chart was actually pretty good. You can see the score was 0.771. After the review, it should come to a 1.253, a difference of 0.48, but it's still, again, conditions that were missed. Case number 5, this is my last one. Based on the provider submission, it's 0.606. Based on the chart review, it should be at 1.994. So, just trying to show you that the amount of conditions that are actually out there that are left on the table. So, again, an underreporting, like Dr. Patel said, is just as bad as overreporting. It's all about, CMS and that bell curve, just about, undercoding your office visits versus overcoding them. Either way, you swing too heavy, it's a flag. So you really need to go through these charts, identify what the conditions are in there, and start to document them. So here we come to the end. Best practices. All diagnoses should be submitted for your risk adjustment payments. Must meet the following. They must be documented during a face-to-face counter, obviously. You must provide full and accurate documentation. You must document the condition, document the current status, and any known treatment plan. Remember.
So Kerry, can I interrupt?
Yes.
Like in this COVID-19 emergency, the face-to-face is almost, can we do the telemedicine during COVID-19 emergency and can document or no?
You can only get credit for MRA scores if you're doing a video call.
Okay, very good.
It has to be like doxy.me. It has to be through the eClinical video, FaceTime call from an iPhone. If you are doing a phone-only call, you will not get credit for MRA conditions.
Great. So I just want to make sure people understand that.
Yeah, it's not considered a face-to-face visit.
Okay.
And then just remember that each one of these progress notes is a standalone note. So should these progress notes ever get reviewed from a CMS perspective, they're going to look at that one sole note. And if those conditions are not supported in that one progress note, irregardless of what's in your chart, they will delete those MRA conditions and scores because it has to be documented and supported every time you document it. You must have support for that condition. And by support is current status, any diagnostic support, and the current treatment plan. Most important. Your final assessment. You should document all conditions and diagnosis that impacts the patient care on the data service. All conditions and diagnosis that are monitored, managed, evaluated, assessed, or treated on that data service should be documented. And all comorbid and coexisting conditions that impact your patient care, treatment, or management should also be documented. Now, for each one of those, you should have a current treatment plan, and it should be very clearly inferred and documented in your note. You should document any time you issue referrals for diagnostic tests, consultants, or specialist treatment for any condition. So, for example, you could say, patient has CHF, referring them to cardiologists, acute, for acute CHF. And that would be enough support in your assessment and treatment plan. What are you doing to address the acute CHF? You're referring them to a cardiologist, a more specialized provider that can treat the acute symptoms. Just remember, you have to, if you get knocked out of this, whatever you diagnose that day must be supported by some type of clinical indication, specialist notes, or diagnostic study, and I must be able to see that in the note. So you have to write it, and then of course the corresponding treatment plan. And if you do that, you will always credit for every MRA condition you document. Lastly, your data submission. Your data submission must or should be a mirror of your progress note. If you have diagnosed 10 conditions in that progress note, you should be submitting those 10 conditions. And if you're not, and if you have a system limitation, then you need to find a workaround. Because more than not, your MRA conditions are at the bottom of your assessment because they're the chronic, not the acute, and you're going to be losing your score. Make sure that all your ICD-10 codes are as current as possible. Make sure, especially if you're using a billing service, please make sure that if you are writing or creating super bills or something to pass on, that they truly reflect what was documented in your progress note. Do not leave that up to somebody else to do. Make sure you're using updated EMR systems with current ICD-10 codes. I encourage all providers that they should have at least one current coding book in their office, because there's a lot of guidelines in there as to when you can use the code and when you can't, that your EMR systems don't tell you. And then again, the use of certified coders or health information management professionals is your best course of action when you are submitting and documenting these conditions. Have somebody review it, make sure you're meeting your guidelines, make sure your documentation supports the conditions being billed, make sure you're using the accurate code before you submit to the plan or to CMS. This way it goes in clean and everything is good to go. You don't ever want sloppy billing to go in, and then you're constantly being flagged for wrong conditions, unspecified conditions, incorrect codes. So your best case scenario is to make sure your super bill and your billing matches your progress note. Your progress note is as robust as possible, and that you are using current and accurate codes. And that's all I had for this evening.
So that's great. Okay, let me tell you, for next, next week, next session, so see if we can teach us about cardiology and kidney problem. So heart, cholesterol, and kidney. See, this was diabetic. You did a great job. Now we know what tests we need to have before we start coding diabetes. So let me tell you something more. So for all the audience here, the doctor's ACO being evaluated for the risk MA program, and Dr. Mayur Bhatt is helping us with that. So first question was how many patients we have who are into Advantage plan, and we gave him a number, and he kind of liked that. The next question is how many physicians are able to do a non-binding agreement with the possible any MA program. So those forms will be sent out to you, and basically what we asking, if we have a deal with the MA program, would you be part of it? And then it's not bind you for anything else, and even we get a deal, you can say, hell, I don't want it. That's up to you. But idea of that is how many our 150 physicians want in that program. So that will give us some legwork for them to figure out that is worth spending time with us or not. So I think Darren will send you that form to sign. It will be on DocuSign. It will be on your email by next week. So please go and sign it. It will take you a minute. Read it about it. If you have any question, you can call me, call David, or we will able. Basically, it's a proper staging of evaluating a group of physicians who will create interest in managed care program. So this is just the evaluation thing. We're not committed to anything. And since we are a high quality, low cost physician group, I think we need to see how much a program value us. So David, you want to add something in it?
No, sir. You had a great summary.
Okay, Dr. Mayur Patel, do you want to add anything in it?
No, you said it right, and definitely with the annual election period coming around the corner, those physicians who already have managed care contracts, I can almost guarantee, it's a big thing to put it out in front of an audience, but I can almost guarantee that we'll be able to enhance those contracts if we can come under a new umbrella with at least one or two payers that I have already gotten a cursory approval to offer a Medicare Advantage risk gain sharing program. So those who already have existing Medicare Advantage patients but are not in risk gain sharing, I can definitely say consider having a letter of intent signed so we can bring the structure to you. Plus we have the flexibility based on the volume of your current Medicare Advantage number of lives. We can tailor make the agreement to a degree so it's a true win-win for you, the primary care provider. Those who do not have as many, and if they are considering or losing their current patients to competing Medicare Advantage providers in the vicinity, in the area, and would like to participate, this is the time to get on board, get credentialed, get in the directory. So the annual open enrollment, annual election period that is in November and December, they can get they can retain their patients and or gain new patients depending on where they are situated geographically. And I'm more than happy to answer specific questions that can come through Dawn or Dr. Agrawal, and I'll email them back. So absolutely be happy to answer questions, but look forward to working together in a collaborative manner.
Very good. Dr. Parani is very active. She asking question, if the patient has diagnosis there, should be supported, but if it is not, bill on the day of service. So what she's asking is there is a progress note. She documented the patient had diabetes or hypertension, congestive heart failure had, but she did not bill for those services. Then what happened to that? Did she get credit or not? Because I think obviously you would not get credit because Medicare would not know that.
No. Well, she certainly has the opportunity to submit a corrected claim. If those conditions documented in the progress note, just go ahead and submit a corrected claim. But that's where it comes into play when what you're documenting. You should, really take that extra minute to make sure it's on your encounter or claim submission form.
Very good. Thank you very much. Thank you, Carrie.
Carrie makes a great point. If it was December, that would be by far the best way to do it. But considering that it's August, maybe you just put that in your reminder that pops up, and then maybe you just bill it next time, and you'll get the same benefit as long as it's billed one time per year. But definitely, if it's in December, you got to submit that corrected claim so you get it within the calendar year. Are you okay with that, Carrie?
That's great. It's 7 o'clock, and this is Carrie hours. Thank you, Carrie. Thank you, David. Thank you, Dr. Patel. And we'll look forward to meet all of you in 2 weeks. Thank you, Alan.
Thank you.
And this video recording will be available of this tonight discussion on doctorsaco.org website. Thank you.